This is Dr. McLaughlin from the University of Michigan and Providence Hospital with a video presentation to accompany the Lancet Oncology article from May 2016. To understand the modern challenge of treating prostate cancer, the challenge of cure with quality of life, we will review the functions that pass through or adjacent to the prostate. The prostate is located in the pelvis, just below the urinary bladder. Urine from the bladder drains into the urethra that passes directly through the prostate. There are two control valves or sphincters, one at the entrance to the prostate and another at the exit from the prostate. When these valves open, the bladder empties. The male reproductive system also courses directly through the prostate. Semen consists of sperm from the testicle and secretions from the seminal vesicle and the prostate itself. Semen enters through an injection port within the prostate urethra called the virum montanum. Completing the male reproductive system are two vascular balloons called the corpus cavernosa that fill to cause erections. The blood vessel supplying the corpus passes near the prostate, and the nerves controlling erections are immediately adjacent to the prostate. The rectum and its sphincter is immediately behind the prostate and is connected by muscle and fiber attachments to the external sphincter of the bladder, the prostate itself. Obviously, treatment of the prostate may affect any function within or near the prostate, and remarkable technology allows us to minimize these effects once these structures are clearly defined. All these structures and their variants can be clearly seen on an MRI. Vessel-sparing radiation is an attempt to preserve erectile function by defining and avoiding erectile tissues. In the technique, prostate is carefully defined by taking advantage of the clarity of the MRI scan. Here we can appreciate that on standard CT scan from every available angle, the boundaries of the prostate are much less clear than on MRI. It is possible to overestimate the prostate by centimeters using CT. By combining three views and fusing them, we can limit the overestimation. Incorporating these images and contouring all adjacent structures is a time-intensive process requiring training in MRI. This is available free online at prostadoodle.com, developed at U of M in Providence. It is noteworthy that in clearly defining the prostate, non-erectile tissues are spared unnecessary dose as well, including sphincters, bladder, and rectum. By the current standard, 80% of men maintained erectile function and nearly 90% reported they were able to be sexually active at 5 years. Future studies will attempt to limit the dose to other structures near the prostate, a greater challenge. Perhaps the most exciting outcome was the fact that erection function was preserved in the most intense form of radiation, combining seeds and external radiation. At U of M, we do the implant first and use the MRI information on tumor location to add extra seeds to the tumor in the OR. 3 weeks later, a CT and MRI are done. The seeds are clear on the CT, and the prostate and critical adjacent structures are clear on MRI. At this point, a dosimetrist, trained in the planning of beam radiation, calculates the dose from the seeds and inputs that into the beam calculation. If the seeds delivered sufficiently high dose to the tumor, then the beam adds little additional dose. But if an area of tumor is not fully dosed, the beam supplements the seeds. The two forms of radiation complement each other. Beam radiation can provide a margin of dose around the prostate, but cannot deliver as high a dose within the prostate. And seeds deliver high dose within, but cannot provide margin around. By integrating these two and directly summing dose, severe complications are limited, while the advantage of very high focus dose to the prostate tumor is realized. This means there is real hope that cure and quality of life can be achieved, even in men requiring more aggressive treatments for aggressive cancers.